Hi, welcome to Walsall Manor Hospital. It's really good to welcome you to our trust. My name is Matthew Forrest. I am a senior advanced clinical practitioner in emergency care with a specialist interest in intensive care medicine. I present this to you today, sepsis in Walsall Manor, particularly within focus of the accident emergency department. But hopefully you can take away from this some learning points, and also to be able to undertake a little bit more about sepsis as you work and progress your way through our trust. I've not written this alone. This has come from a collective amount of people. So within the emergency department, we wrote this. So big thanks to Miss Joshi, who's the clinical director for emergency medicine, Dr. Andrew Foote, an A&E consultant, and senior sister Sam Allen, a practice development nurse in emergency care. There's been a big change in relation to how we think about sepsis. This is not a new thing. Um, many people have already spoke about sepsis. We're now in sepsis 3 toolkit stage. And so we're seeing complete differences in the way that we initially managed sepsis to how we should be managing sepsis now. Sadly, with the pandemic, we've had a focus that has been predominantly on coronavirus. But actually, what we've missed out is the fact that there's lots of other things that have been happening. And the introduction to Sepsis 3 and some of the changes that have occurred really have not been highlighted. Yet, the public still remain to be very aware of what sepsis is. And as I've said, this is not a new thing. Sepsis has always been around, but we've educated the public more now. It's on the side of ambulances, it's on your cornflakes, it's on every little bit that we see throughout our media exposure. We see sepsis. Iceland put it on their milk bottles now. We're seeing it in everyday life, and people are talking about it. And more than anything, people are dying from sepsis, and these common things where people are dying of sepsis are now being focused upon them in the media. And so, what my plea is to you is realistically, we need to be at the top of our game for sepsis. And people know what sepsis is, people know what heart attacks are. And therefore, these are the things that you need to be the experts in. I'm not an expert in sepsis. I have taken a lot of this presentation from other people named upon the presentation seen in front of you, and by seeking help from other people. We're lucky enough to have a sepsis lead practitioner in a local trust that I've managed to get hold of, and they've offered lots of support for this presentation. So once more, thanks to those people. Like anything, things go in circles, and this is what I like to see on this presentation. Things will come and go as we see new and evolving research. So some of the things we talk about today are old ways of doing things, and I'm introducing the new way that we should be managing sepsis. So hopefully we'll take something from this, we'll develop into our careers, and we'll go forth and manage people with suspected sepsis appropriately. Listed in front of you are the aims of what this presentation is going to offer. The definition of what sepsis syndrome is, the single most important intervention, what is the mortality from sepsis, and how many people actually die each year from sepsis that we know of. Sepsis costs the economy a lot of money, but here at Walsall, we need to ensure that all of these things are being dealt with appropriately so that we manage our patients appropriately. And so we're going to explore how Walsall are doing in relation to sepsis. And what are our next actions for managing sepsis from here? So to appreciate what is sepsis, let's have a look at firstly at what the pathophysiology of sepsis is. Of course, the first thing within sepsis is that there has to be an infective cause. Some time ago, we used to talk about SIRS criteria. Now, SIRS criteria is no longer of a focus, But actually, it still remains part of the pathophysiological approach. Although we don't talk about SIRS criteria anymore, SIRS still occurs in the human body. The human body is a really clever thing, as we well know. We've studied enough to know that already. But actually, it can put itself into harmful places. So as we progress through this, let's always think about that all of our actions in our body are not always for the preservation of life, but actually it's part of that chemical mediation as well. It's almost like having that chocolate bar that you know you definitely shouldn't have because it's going to put extra couple of pounds on your waistline, but you know it tastes so good and you know that it's the right thing to do. So, as we get an infection in our body, we have a systemic immune system response, SIRS response. And this releases a mediation of chemicals from the endothelium. So when we look at the way that we have when we look at the mediators, the chemical mediators that occur, although they're designed to fight the infection, that communication then leads to a cascade of other things. So we get vasodilation, we get that capillary leakage, we get the initiation of clotting cascades. And so we see our body responding in a positive way, but actually having also negative effects also. And within that, that decreased perfusion from the vasodilation and the capillary leakage then leads to multi-organ dysfunction, predominantly in the kidneys, respiratory system, cardiovascular system. We get that intravascular dehydration. We get that depletion of our clotting factors, which leads to uncontrolled bleeding or a DIC. And we get the prolonged corticosteroid release, which then leads to prolonged, slow failings of our organs where our mitochondria aren't able to help heal our organs and our cells. And so what we see here is a ever circle, a continuous problem reoccurring. And so the quicker we are to manage this, the better we are to prevent end organ multi-organ dysfunction or end organ failure, to prevent our DIC, and to prevent our immune system failure, ultimately leading to death. So what is sepsis? Well, we've seen sepsis noted to be multiple different things before. In front of you, you can see that there's lots of different things that have been said. And I've already mentioned about limitations of SIRS criteria. And we had multiple different definitions where people would say someone had sepsis, severe sepsis, septic shock, and actually no one could differentiate in clinical practice what the difference was between a patient, because often a patient would slip in and out of different phases. So this has been completely suspended. So do not think of this as sepsis. But what we need to now look at is what the Sepsis 3 is telling us. And so the third international consensus definitions for sepsis and severe sepsis have been released. And this is in the new Sepsis 3 toolkit. And they mention two definitions only: sepsis or septic shock. Sepsis is a life-threatening organ dysfunction due to a dysregulated host response to an infection. Septic shock is a subset of sepsis, so it's exactly what sepsis is, where underlying circulatory and cellular metabolic abnormalities are profound enough to substantially increase mortality. So septic shock is the shock from sepsis, is the basic way of recalling that. And so with these definitions, it is hoped that you will see patients in a different way. Rather than severe sepsis or septic or non-septic or septic shock, a patient is either septic or they're in shock from the sepsis. The SOVA criteria is one of the predictors for mortality, and although this isn't predominantly used within the accident and emergency department, it is most definitely used in acute medicine and intensive care medicine and in surgery. The sepsis clinical criteria is that organ dysfunction is defined as an increase of 2 points or more on the SOFA, so the subsequential organ failure assessment score. So sepsis is affection with an increase in the SOFA score, which then leads to a 10% mortality. Now, what we know is that it's not as sensitive as SIRS. It needs some degree of interpretation, and we know it's not great for emergency department use. But we should also appreciate that. And so when you look at this, and I appreciate this is quite a small table for you to have a look at, but if you look at it either on Google or in one of your textbooks and look at the SOFA score, so when you look at this, 4 is the highest score, 0 is the lowest score, and you're basically giving points per abnormality in those aspects. So, what is that coagulation? What is the liver doing? What is the central nervous system doing on the GCS scale? What is the renal function doing? And so as we see this, we can then detail what the risk of mortality is. As that increases higher and higher and higher, our increase in mortality becomes higher and higher and higher. So who does sepsis target? Well, to be completely honest with you, sepsis can go for anyone. Anyone can be septic, but there are specific groups that are of higher risk. And these are children, maternal patients, elderly, and those are immunocompromised, so those on chemo, steroids, who are diabetic, HIV, so on and so forth. These particular groups of people are of higher risk, and there's lots of different reasons for that. We know the elder, we know the paediatrics are at higher risk of sepsis, but actually we are of less sensitive to these individuals, and the reason for that is because they present in different ways. Either they don't communicate that reduction in urine output because they're 2 years of age, or they're living with dementia, or your maternal patient doesn't present as such because actually there is a complete differences in a adult observations via news 2 score to that of a maternity early warning score, and that needs to be appreciated. Maternal patients who are pregnant and postpartum, do have varied different levels of observations, and so when you are assessing or seeing a patient who is pregnant or postpartum, you should take into consideration the modified maternal early warning score. In children, you should really inquire with their parents about reduction in urine output, or whether they're tolerating fluids as much. And definitely with the elderly, for patients who are living with things like dementia or Parkinson's disease, or those that can't communicate as English is their first language, or they may well be deaf or may not understand you due to a disability that may be hidden, we need to inquire more. We look to have lateral collateral information in order to develop our understanding of how unwell or well this patient should be. And never ever dismiss a patient who may well be on chemotherapy, on long-term steroids, who is a diabetic or lives with things like HIV or AIDS, because these individuals will be more at risk. Now, we see this in the media. I talk about the media quite a lot. It's everywhere. But we see that a boy, 17-year-old, died when bundling doctors misdiagnosed his blood poisoning 4 times, thinking it was flu. Now, when you appreciate this article, it was written in 2012. So when we look back at 2012, NHS was under extreme pressures, funding was as low as it ever has been, and there was lots of other things going on. But actually what we see here is that his condition was dismissed by doctors and paramedics all up until 6 days before he died. And his mother was told that his condition didn't warrant a hospital visit, and that even though when he started coughing up blood, that this wasn't anything to be worried about. Now, I think a person that presents with flu-like symptoms, who's got hemoptysis, who's had multiple healthcare professionals review them, probably definitely should have a review in hospital and probably should have bloods undertaken. Not being aware of the whole situation around this case, it takes it into poor context. But this is just the poor, this is a media's portrait of what happens with a patient. Now, there may well be more or less taken associated with that. But when you see articles like this, you can appreciate why the public are so scared of the word sepsis. This was readily available. Now, I have amended some of these figures, and the reason for that was this is quite an old sort of like presentation slide that's been taken. But actually, when you look at this, it gives you some great detail. So, teenage Patrick Kane uses bionic hand after he's lost his fingers and contracted meningococcal septicemia as a baby. Now, Ron Daniels above, who's the chief executive of Sepsis Alliance and obviously now the Sepsis Trust, very clearly stated that this person was lost his arm from sepsis, and we know that and we acknowledge that that occurred. But what troubled me more than anything is he's now living with the consequences of what sepsis was. And so he, every single day, has adapted very clearly, very well to losing his arm. But what worries me more is the fact that people are adapting to sepsis, and so our impact may have long-standing issues upon them. So it may not always be health-related issues, but it can be mental health issues or functional social issues. So sepsis in itself is not just a medical problem, it is a wider issue. 6 million newborn and small children are killed by sepsis every year in developing countries. Now, we are a developed country here in the UK, but that's still quite a staggering number for developing countries, and their access to healthcare isn't as good. But what we also need to appreciate from that is children are very, very vulnerable to sepsis. And so when you are seeing a child that may present with sepsis, it is really important to ensure that we undertake that sepsis 6 criteria very, very quickly, as it's proven to be more effective if it's undertaken within the 1 hour period. And we'll talk about that a little bit later on. What we see here is that actually the impact upon the healthcare is quite big. When we're looking at £2 billion a year in Britain alone just on sepsis, that's a staggering amount of money. And when we look at how many people are affected by that, and we take into account, numbers in itself, we can't appreciate numbers when they're listed up on our presentation in front of us. More than 200,000 people in Britain suffer from sepsis each year, of which up to 75,000 of those die. Now, if we take that into perspective for imaging and we see a football pitch in front of us, you can imagine this is Italy versus England in the Euro Cup final. Hundreds and thousands of people are still there despite the coronavirus pandemic being present and social distancing undertaken. Imagine a full stadium at Wembley. When we put in perspective about how many people die from sepsis, probably one smaller stand actually, of those people in a football stadium will die of breast cancer in their lifetime. A larger one will die of bowel cancer. But actually all 4 stands in that football stadium will die of sepsis in the UK alone. And that's quite substantive. I've already mentioned Dr. Ron Daniels, but if there's a link there, I would really encourage you to go and have a look at that link and look at his video about how he talks about how sepsis affects people, and to really put into context and appreciation as to what sepsis can do to our patients and how it can also affect our healthcare professionals as well. So what do you need to do? Now, this presentation's been very much designed around introduction of new doctors, new nursing staff, and also existing staff. So, what we just ask you to do is arm yourself with the knowledge of what sepsis is, appreciate early triggers and escalation to you, and follow the Sepsis 6 criteria. Here at Walsall, we use vital packs as part of our daily observations or hourly observations, or how according to you, how regularly you opt to do them. And this will trigger sometimes the questions whether a patient should be screened for sepsis or not. And so this is our preferred method of collecting this information and escalating. In the emergency department, we are also moving to our care flow questionings, and our Sepsis 6 performance will be up on there. So look out for that. But what we ask is to ask yourself the following questions. Does the patient look sick? Or is there a single, 3, or combination of 5 or more on a news 2? So, number 1, does the patient look sick? If a patient looks sick, you must ask yourself, should I be treating this patient for sepsis? Now, we appreciate that people look sick for many different reasons, but it's just a simple question. This patient looks sick, should I be considering for sepsis? It may well not be needed. You may have a patient who presents with breathlessness secondary to a pneumothorax. The patient may still look sick, but they don't need treatment for sepsis immediately. They need their ABCDE management undertaken. But a patient who does look unwell, with no obvious cause as to what's making them unwell, may well have sepsis, and this also needs to be considered. Now, Sepsis 3 Toolkit talks about a news score of 5 or more, but the Royal College Physicians still state that a single trigger of 3 should be escalated in the same urgency as a score of 5 or more on the news 2, and you should undertake a sepsis screening tool. Now, in 2020, the sepsis screening tools changed to the one that you can see on your screen. Not everyone's changed to this at the moment, but these are what we're using here at Walsall. We've definitely adapted these very quickly. And so what we ask you to do, although it may not be in paper form here in Walsall, it is still electronically on Careflow and Vital Pack for this to be completed. So for nursing staff must complete this. For medical staff, you should ensure that you are approachable for escalation, that you consider the patient to either look sick or not look sick, and that you ask about the news score. And if you see a single 3 or a combination of 5 or more, you should be asking yourself, should I be treating this patient for sepsis? Now, the NICE have released a lovely guideline, and I appreciate that this is quite small upon your screens. But if you go into Google or you go onto the Trust Internet and type in sepsis, this will come up quite nicely. It's the NICE guidelines for managing sepsis. And this is the process that goes through. So I'm not going to talk about this so you can go and have a look at this yourself. But these are the actions that need to be taken and the screening tools that need to be undertaken in order to manage a patient for sepsis. The Sepsis 6. Previously, we've all known sepsis to be 3 in, 3 out. And we've practiced that for a long, long time. Sadly, it's changed. And it's changed not always in the good aspects, because we all remember 3 in, 3 out. But actually, it has changed for the best interest of the patient. So let's go through this now, and at the end, hopefully, you can take a picture on your phone and use this and take this with you. So number 1, ensure that a senior clinician attends. So going backwards into this, and I hate to flip backwards and forwards, but going back into that flow chart that you saw from NICE, the escalation has to be to a senior clinician. Now that needs to be a ST3 or CT3 or above, or an advanced clinical practitioner in the emergency department or hospital at night, ITU, surgery and so forth. They have to be a senior clinician. So your ST3 or above, or your qualified advanced clinical practitioner, needs to go and see the patient. Number 2, give high flow oxygen via a non-rebreathe mask. Now, this is always one of those questions. A patient who presents with COPD or has a background in COPD and they are meeting sepsis, should you give high flow oxygen? Well, the question is if that patient's hypoxic, or as we understand from that pathophysiology that we reviewed earlier on, the patient may well be hypoxic and have poor perfusion. So a little bit of high flow oxygen is not going to harm them as long as it's in short term. So for nursing staff, if you think your patient's unwell, you should give them high flow oxygen. For medical staff, you should consider a targeted saturation to maintain, if they are not COPD, between 94 to 98, and if they are COPD, between 88 and 92%. Number 3, obtain IV access, take blood cultures and lactate, and consider source control. So you're going to take the bloods, you're going to send off an FBC using E as a CRP, you're going to send off your cultures, but I also want you to consider your source control, because this isn't always appropriate to every patient that presents acutely with a chest infection. You've put a line in, consider existing lines as a source of sepsis. Do they have a Hickman's line? Do they have a PEG situ? Do they have a catheter in sight? Do they have a drain? These are things to look at. So as you're obtaining IV access, you're putting another tube in, check all tubes and indwelling catheters. Number 4, give IV antibiotics according to the local protocol, which is available via our trust intranet, within 1 hour. Now, I bold the point of within 1 hour because that's what we aim for, and we'll discuss about the timings in just a few seconds. But if we can get it in within 1 hour, what we know is that the patient's more likely to have a reduction in mortality, but also that patients had immediate treatment within 1 hour, and what we can attain from that is that a patient has been managed appropriately. Number 5, start IV resuscitation. The recommendations is not always now for normal saline. Normal saline is okay as a immediate resuscitation fluid on a one-off bolus or for mixing drugs. The recommendations from Sepsis Trust and NICE guidelines, intensive care therapy medicines and journals, and also more recently in the Resuscitation Council guidelines from 2021, that actually what we should be resuscitating patients with is things like Hartmann's, or as we use here at Walsall, plasma light. Number 6, monitor. So we need to keep our patients monitored. Now, it doesn't mean that a patient needs to go to a high dependency area for full invasive monitoring, but what that means is that we should still be doing regular observations on our patients in accordance to the News 2. We should be considering monitoring our patient's urine output, maybe considering a catheter. But if that means that that patient needs to be escalated to a high visibility monitored area in acute medicine or in surgery, or if that patient needs to go to our resuscitation room or our high dependency cubicles, or if that patient needs to go to high dependency level 2 bed or intensive care level 3 bed, then that should also be considered. And hopefully all this gets done within 1 hour. So a research paper undertaken by Kumar et al. Back in 2006 reviewed multiple different patients' mortality and survival in septic shock. Remember the old terminology of septic shock, based upon the antibiotic delay. And they found that for each hour, delays in administering antibiotics in septic shock increased mortality by 7.6%. Now, this has been argued many times, and we saw that this was also part of our our College of Emergency Medicine clinical audits back in 2011 and 12, that mortality increased with delayed IV antibiotics. And so this was when a big push came forward that IV antibiotics need to be given within 1 hour. We have had, in 2017, Mervyn Singer wrote a paper, a Lancet paper, saying antibiotics for sepsis, does each hour really count, or is it just amplified? And ultimately, what was found was that there wasn't a massive delay between the 4 hour and the 1 hour marker of giving IV antibiotics in relation to mortality. It was of nil real relevance. But what that highlighted was that patients actually met amber septic symptoms. So they weren't red flag sepsis, they were amber flag sepsis, as seen upon our NICE criteria flowchart. And obviously, when we got the U's and E's back and the bloods back, we then treated them with sepsis. But actually, they didn't have a mortality difference between those managed within 1 hour and those managed within 4 hours. But what Kumar et al. Did and what Anderson et al. Did in 2019 was particularly look at red flag sepsis and the delay of antibiotic treatment, which showed high mortality in patients with onset of sepsis in Sweden. This one was, but also obviously in Kumar, predominantly within red flag sepsis. So what we need to take from that is red flag sepsis really should be managed within 1 hour, because it reduces mortality, and it increases if we delay it by 7.6% each hour. Those that present with amber flag sepsis, we need to follow the protocol appropriately and identify whether that patient needs to have the antibiotics sooner rather than later. Interestingly, what I've just done is show that actually the chem audit that was undertaken back in 2012 actually only found that 27% of patients received IV antibiotics within 1 hour, and that was really poor upon the College of Emergency Medicine. Massive changes have occurred from there. But if we look at what sepsis, and this has come directly from the UK Sepsis Trust, when we look at what the Sepsis Trust say in perspective, when we compare acute coronary syndrome, so MIs, non-STEMIs, ACSs from unstable angina, compared to severe sepsis, what we can actually see there is quite poor care. Now, ACS management involves clopidogrel, aspirin, and a beta blocker. And obviously, this is quite old data, so it still looks at thrombolysis versus PCI. But also, what we're seeing there is the sepsis. So, the Sepsis 6 in the data that was provided by the Sepsis UK, or the UK Sepsis Trust, sorry, showed quite poor comparative care, didn't it? You know, number of cases per 100,000, 240 per 100,000, and actually only 4 per 100,000 of those got sepsis 6, and the first hour of antibiotics was 6, compared to that of ACS, where 48% of patients got clopidogrel, 26 of aspirin, 42 of beta blockers. And when we look at invasive care, and we see that actually sepsis has been poorly managed for many years. Now, this is old data, like I've said. I'm hopeful that this will develop, and future prospective comparisons will prove that actually these are on par with each other. So, Warsaw Manor, what are we doing about it? Well, where is Warsaw's data? Beforehand, before we actually designed this presentation, data for sepsis was quite limited. In fact, it was undertaken, but it was poorly communicated and very little actions were undertaken. We've learned from this. And what we're actually doing now is a lot of our data is proven that via vital packs and via completions of care bundles and so forth, that we manage patients with sepsis around 92% of the time within the first hour. But we do fail in some aspects. So big pushes from Warsaw and big messages to put across is neutropenic sepsis, a patient who presents with chemotherapy, feeling unwell, or even report any temperature, we give IV antibiotics, tazocin or meropenem here. Any patient that presents as looking unwell with a high NEWS, you ask yourself, could this be sepsis? And you undertake a sepsis screening. Now, I don't have up-to-date information, data for you to look at. But what I do know is that in the emergency department, on our last look, we were at 92%. And then we had a bit of a drop, and then we've come back up again. And like I said, as this becomes more and more public domain driven, and healthcare professionals start taking responsibility for sepsis screening and sepsis management, we will see an increase. But high 90s, more than 95% of patients is not undoable and should be our aim. Ideally, we want 100% of our patients to be screened, managed within 1 hour, and escalated appropriately. What's next? In the emergency department, we've developed our own action plans for how we're going to look at sorting sepsis. So that involves screening every septic patient, looking at PGDs for people that are ALS providers to give IV antibiotics, pre-calculating paediatric dosages, actually having an internal department aim to try and get antibiotics in within 30 to 60 minutes is our aim. By developing healthcare professionals to be allowed to take blood cultures, ensuring that lactate is undertaken for patients that look unwell, and also pushing that documentation and completing the sepsis toolkit via Vital Pact or Careflow. As a wider trust, the trust of developing a deteriorating patient and septic patient protocol for people to follow. We are pushing training and teaching, and we're really encouraging every single person to really take ownership of sepsis and to push forward, asking the questions, could this patient be septic? And appropriately managing them within 1 hour. Now, microbiology is one of those things that most medics ask. You must look at your local microbiological guidance. But in basics, we use triple therapy for unknown sources, body-specific microbiology antibiotics, for neutropenic tazocin and meropenem, and for paediatrics, ceftriaxone only if they're over 3 months, or cefotaxime and amoxicillin if they're under 3 months. So, it's your first day at work. Let's go through some scenarios. A 52-year-old female presents with lower abdominal pain, cough, and shortness of breath for 3 days. She's brought to the emergency department by ambulance. In the rapid assessment area, her observations are as follows: a heart rate of 110, a respiratory rate of 29, saturations of 91%, on air, oxygen has now been applied and they are 98. She presents confused with a fever of 37.9. What is the next course of action? Take a couple of seconds just to have a think about this. Maybe jot it down, maybe think about it out loud. So we want to gain IV access on this patient, take some bloods and cultures and a VBG, and check that blood glucose. Remember, that patient is confused. So that patient may well be confused due to delirium. That patient may well be confused due to underlying infection, and confusion in itself is a trigger for sepsis. If a patient presents with new confusion, this is a trigger for sepsis. You got the result of lactate of 3.8 and a glucose of 4.9. So the glucose is reasonable, but the lactate is elevated. So we know that either hypoxemia or hyperperfusion has occurred. So we might consider using our PGDs, or if you're a medic, you're going to prescribe a broad spectrum antibiotic for the patient. You know, she's presented with a cough, abdominal pain, she may well have a urine infection, a pneumonia. These are really difficult things to highlight. So actually hitting her with broad spectrum until you find the cause may well be the best action to undertake. For nursing staff, we're going to triage her as a category 2 using the Manchester triage tool. If it was on a ward, we may escalate early. We may then turn around and say, actually, this patient's news score is elevated. I'm going to call the doctor. Or if the patient looks unwell, you're going to put out 222. You need to start documenting sepsis and complete the sepsis bundle. For junior medical staff, you will escalate to a senior clinician and get them to review the patient and ensure that clinician of seniority attends as soon as possible. Remember, this is time stamped upon the care bundles when IV antibiotics are given, fluids are given, blood's taken and cultures sent, and when a senior clinician attends. Second scenario. A 71-year-old male has presented with a 4-hour history in the resuscitation room and is being managed as a community-acquired pneumonia. Guys, I apologise that this is predominantly emergency department based, but I will try and adapt it as best I can. Imagine that patients on AMU if you're going to medicine. You are now taking over the care of the patient. We've achieved a full sepsis 6 in the emergency department within 1 hour. He's had IV antibiotics and a total of 3 litres of fluid, 3,000 mils of fluid. His observations are now as follows: heart rate of 136, a respiratory rate of 34. He's alert, his temperature is 34.5, and his saturations are 93% on 4 litres of oxygen. Assume he's not got COPD. What actions will you undertake? Take a couple of seconds to think about it. So some of the suggested actions are that we're going to need an urgent review. Now, if this patient's in the emergency department, you can ask a senior clinician in the emergency department to review the patient if you really seriously feel that patient is very unwell. Or, potentially, if they're under medical care, the medical registrar or the consultant may need to consider seeing the patient. You may also inquire about asking ITU to review the patient. Given the fact that patient's already had 3 litres of fluid, they're probably going to need some inotropic support. Ensure that you document your concerns. Documentation, time-stamped and name-stamped, is vital and is very crucial in escalating care and making sure that you have undertaken the appropriate action. Consider repeating a VBG or, ideally, an ABG in this patient. He's got a community-acquired pneumonia, he's got an increasing oxygen demand, and he's had a lot of fluids. He may have underlying heart failure. We may have put him into a CCF. He may well be hypoxic due to the fact that we're needing to oxygenate him. He may need to go on CPAP. Or his lactate may not have de-escalated. His lactate may well be increasing or plateauing compared to the previous one undertaken in the emergency department. And we're also going to document what urine has come in. So what document fluid in and document urine out on the fluid chart. We expect some medical intervention, so we want to consider inotropic support. We want to consider level 2 or level 3 care. And we also need to consider about our escalation. Is a do not attempt resuscitation appropriate? Is a respect form appropriate? Is this patient for full escalation? As a trust, for senior clinicians, that is of ST3 or above, or advanced clinical practitioners, we have a metaraminol for severe sepsis shock protocol guideline written, and this is available via our Ask Earl app or by going to www.askearl.co.uk or going via the internet to the intensive care page and looking at the metaraminol infusion guideline. Now, this can be undertaken by the emergency department in acute medicine or acute surgery before ITU attend, but you must get ITU's permission to start metaraminol. Scenario 3. A 5-year-old child presents following concerns of a high fever and reduced fluid intake and a wheezy presentation. Child has been admitted prior with bronchiolitis. Mom has asthma. The child has recently been coughing. The child is working hard, accessory muscles are in use, and there is severe recession. The actions to be taken are down to you. The observations you can see: SATs of 88, respiratory rate of 56, temper 38.7, heart rate 186. Take a couple of seconds to think about what actions are expected to be undertaken. So we've got a sick child here. Now, if you are a junior, you are going to be seeking help, and there is nothing wrong with anyone getting help at all. Put out the 2222 call if you need to, or get your consultant to see the child immediately with you. You're going to start the Sepsis 6. Now, it's not easy to cannulate a child. You may need a paediatrician to come and help you, or in the emergency department, you may need the expertise of senior clinicians. You're going to consider some broad spectrum antibiotics, and in this case, you're going to consider things like ceftriaxone. You're going to want to get a gas. It's not always easy to get an ABG from a child. In fact, it's not easy at all, and it's very rarely done. But what you can consider is, as you site the cannula, getting a venous blood gas. Or if you can't get a cannula in, and the patient's too awake or well enough to not require intraosseous access, then what you can undertake is a gas from the capillary and intramuscular antibiotics. But remember, if you do have an unwell child, do not delay in trying to get IV access. In a very, very unwell child, get IO access. But remember, the sample from the intraosseous cannot be put through the gas machine, and so a cap gas will need to be required, or when venous access is obtained, a venous sample is sent. You're going to early escalate to peds. Potentially even this child may require a secondary transfer to a tertiary centre. For nursing staff in the emergency department, this patient's going to be categorised as a category 2. And for good measure, no matter where you are, PAU, Ward 21, emergency department, or, in urgent care, you're going to want to consider actually undertaking a wet flags calculation and a kids calculation printout for this child in preparation for deterioration. Scenario 4. A 29-year-old female presents following a 5-week postpartum delivery with suprapubic pains. She's experiencing dysuria. Her observations are as follows: heart rate of 108, respiratory rate of 19, blood pressure of 143/101, and a temperature of 37.9. Have a think about what actions should be undertaken. So we're going to want to undertake a meow score upon this person. Now, I'm hopeful that everyone's picked up a meow score whilst we've had a couple of seconds to think about this. But let's have a quick look at them now. So the observations undertaken, so the patient had a heart rate of 108. When we look at a meow score, a heart rate of 108 does actually score 1. That's a concern in the fact that actually in a normal adult that doesn't score really at all. The respiratory rate is 19. Well, that would score a 0. Blood pressure of 148/101 would then also score another 2 points. So a systolic blood pressure of 148 would score 1, and a dystolic of 101 would also then actually score 2. So that's a combination of 4 in itself. Temperature of 37.9 does trigger on a meow score, and that actually scores an immediate 3. So already we're looking at a meow score of 7 of this patient. In the emergency department, most patients who presented like this, most people would think this is just a simple urine infection and may consider referring the patient over to the urgent care centre. But with such a high meow score, the patient actually triggers for sepsis and should have a maternal sepsis screening undertaken and have IV antibiotics, fluids, and a referral to the gynae team or obstetrics team for admission. Now, there are many questions which may come from this presentation, and I appreciate that it's difficult in a virtual aspect to ask questions. So I'm more than happy for you to email me via our own internet email. My name's Matthew Forrest, double T double R, and I'm more than happy to answer any of your questions. I hope that you've taken from this some learning points. I hope that you will go forward and enjoy your time here at Walsall Manor. But mostly just remember that our patients are at our end of our bedside manner, and our knowledge and our application of skill. And those that present with sepsis really should be treated as equal to those of higher priority patients. So your cardiac arrest patients, your major trauma patients, your patients that you're going to do world renowned surgery are as unwell as the septic patient. So remember to treat patients who present with sepsis within 1 hour, to undertake the sepsis screening, to give the treatment, to escalate and inform a senior person at all times, and document it. Guys, I hope you enjoy your time here at Walsall Manor. If you have any issues, come and find us. But until we meet again, all the very best to you, and goodbye.